Good morning, everyone. I don't hear you. Good morning, everyone. I'm so honored to be here, and thank you, Dr. Jackson, for that wonderful, warm introduction. I loved what you had to say, which I think resonates very much with my own interests. I'm a clinician. I spend my time when I'm on the wards taking care of patients, and there's not a day that passes that I don't go down to the radiology suite to see my colleagues and get their opinions, taking students and residents with me as often as I can. I would imagine that you are the closest clinical group that I work with, other than perhaps the microbiologist, because I am an infectious disease person. And over the course of 40 years, I've had the opportunity to watch your field evolve, just as you have, from the days of the light boxes to the evolution of nuclear medicine and more sophisticated imaging. In fact, I think all of us who come down to your suites are always consumed by monitor envy when we leave there, thinking how many monitors you have the privilege of looking at. It would be fair to say that you have been at the forefront of the raw technological computer evolution, especially in the area of imaging. But in my field, we've witnessed similar evolutionary trends, very exciting: genomics, proteomics, metabolomics, big data, population health. I'm not always clear what those terms mean, and I wanted to share with you a slide I saw recently at a conference that depicted what big data was all about. It said, big data is like teenage sex. Everyone talks about it. Nobody really knows how to do it. Everyone thinks everyone else is doing it, so everyone claims they're doing it. I like this slide because that was my state of mind until I saw this particular study. And let me set your hearts at ease. This is not the kind of paper that I usually find myself scanning, but I was interested in this paper because the senior author, Mike Snyder, is a colleague at Stanford, and also because the entire paper was about Michael Snyder. It was an intense study of one individual. And this is the moment that I began to understand big data. So bear with me as I walk you through this. If you look at the panel on the top left that's labeled A, you will see that they studied Mike very, very intensely for almost 400 days. And they weren't just doing CBCs and differentials and so on. They were doing genomics, proteomics, metabolomics. I can't even pronounce the things they were doing. During the course of those many days, he developed two discrete infections, a RSV infection and an HRV infection. One of those triggered diabetes, became diabetic. And in his genome, there resided the propensity for that was pretty much turned on by that particular infection. On the right side, panel B, top right, you will see all the tests they performed and the very sophisticated computer integration that they do. And this is called a IPOP analysis, integrated personal omics profiling. And then at the very bottom, you see this circus plot, which is a depiction of the chromosome ideogram with deletions, duplications. Again, this is not my kind of data, but I'm showing this to you because the entire information on this one individual for this period of over a year is more than is in the entire Library of Congress. Just to remind you, the Library of Congress has something like 838 miles of bookshelves, 135 million discrete volumes of books, and 153 million other items, and one individual's data eclipsed that. Now, this is not even including the sort of imaging data that is in your possession, and this was my moment of understanding what is coming down the pike with individual patients in the years to come. But I want to backtrack. I want to sort of ask, when did this all begin? When did diagnostic medicine take on this kind of sophistication? And to me, when I ask medical students that question, when did diagnostic modern medicine begin, they'll often say Hippocrates or Galen or Paracelsus, but in my mind it really began with this individual, Joseph Leopold Ohnbrugger. Ohnbrugger was a physician in Vienna. We're told that his father was an innkeeper, and one of his seminal childhood memories is of going down to the basement of the inn with his father and watching his father tap on the sides of casks of wine, trying to find where the meniscus was so that he could reorder. And basically, this was the method, tapping on the sides of casks of wine, that Ornberger brought to clinical medicine, and we call percussion. Everything we know about percussion, every single thing we know about percussion, with the exception of two signs, he described in this book called Inventum Novum, which, if you think about it, was the ultrasound of its day. There was no way in life to look into the body. But by this method, you could find fluid around the lung, you could find organ enlargement, you could determine whether there was cardiac enlargement and so on, crudely, admittedly, but for the first time, there was this possibility. This technique, unfortunately, was hardly picked up in his lifetime until Corvisart, who was Napoleon's physician, found the text, translated it into French, and all of a sudden, percussion arrived on the continent. And it was followed very quickly by the discovery of the stethoscope, by Laennec, the same Laennec of Lennox cirrhosis. You know that the stethoscope, even though the stethoscope was discovered in this era, physicians were listening to patients' bodies for a long time. Hippocrates described the Hippocratic succussion splash of a hydropneumothorax. But as you can imagine, there are aesthetic challenges to putting your ear in someone's armpit in the course of a high fever when they've been hospitalized for days. And so Laennec, the story is, was walking through the streets of Paris and saw two boys playing with a stick, and one was scratching at one end and the other was listening at the other end. And basically, as you see in this famous painting, Laennec's first stethoscope was nothing but a solid cylinder, which then became hollow, and then which evolved into the present-day stethoscope. And it was followed by a succession of quick discoveries on the heels of that. So percussion, the stethoscope, the blood pressure cuff, the ophthalmoscope, the description of the reflexes and the reflex descriptions and their diagnostic yield. This was an explosion of diagnosis in medicine around 1819. And I think of that as a watershed moment in medicine, because if you remember, prior to that, no matter what ailed you, you went to see the barber surgeon. And the barber surgeon would cut your hair short at the sides, long at the back, pull a tooth. If you were ill, they made no attempt at diagnosis, but they would cup you, bleed you, and purge you. And for some of my medical students, it's still a revelation when I point out that the red and white barber pole is a vestige of that legacy, of the bloody bandages hanging out of the window. And so the moment physicians began to carry stethoscopes in their pocket, they were signaling their intention to make a diagnosis, not to empirically cup, bleed, and purge, but to try and situate the disease in an organ, make a type of disease classification if they could. So this, to me, was a seminal moment. This is when I think modern diagnostic medicine really began. Now, I want to share with you some classic photographs that are in the Osler collection at McGill. This is Osler, William Osler, who in America we consider sort of the granddaddy of American medicine, American internal medicine, certainly. This is Osler inspecting at the bedside, Osler percussing and palpating, Osler auscultating, and finally Osler contemplating. Osler did something like 1,000 autopsies in his lifetime. And that's what it took to make the kind of correlation between what he was seeing on the body and what was actually going on. There was no easy way to do it. He made hundreds of observations in so many different systems. I always wonder, how good would Osler be today if he could make the sort of instant connections that we make? He had to wait for an autopsy, and he had to do it himself. At one point in Montreal, he did 800 consecutive autopsies. Can you imagine that? It speaks to his industry, but it also speaks to the kind of things we take for granted that they simply did not have. I love this last image the most of all, I think, because it also points to a step that we don't do often enough, which is contemplation. And I like this last image because it also has echoes of a very, very famous painting, perhaps the most famous iconic painting in medicine. If you don't know this painting, I'm really privileged to share it with you. This is called The Doctor. If you're at a dinner quiz and someone asks what's the most famous iconic painting in medicine, this is it. It represents a moment in time when artists were being challenged to paint things other than mythical objects or biblical themes, and to begin to try and depict the reality of human existence. And Luke Fields was challenged by Tate, the same Tate who built the Tate Gallery years later. Tate was a sugar baron from the Caribbean. He was challenged by Tate to paint a painting of social importance, and Luke Fields decided that he would paint the doctor in our time. And he was moved to do so because of his own experience with physicians. His oldest son, Philip, aged 9, died on Christmas Eve, and the doctor held vigil for 2 days with the family. And he was so taken with that he decided that he would depict the doctor in our time. And it's interesting, when Fields was interviewed about this, he was never one to mention the son dying and so on, but we now know that's the case. And I want to just take you through the painting, because I think, first of all, you guys are experts on images, and secondly, because I think it's instructive. As you can see, the center of the painting is dominated by the very sick child. And the child is lying on 2 dining room chairs that have been pulled together, so perhaps this is a child who otherwise would be sleeping on a straw pallet in the back of the house. The child looks moribund. There's something about the posture of that hand that suggests a very sick child. And the child divides the pictorial space. So the parents on one side, the doctor on the other side, and you can see the parents are looking on. The father's looking on very attentively to the doctor's face for some sign of what direction this is going to go. And meanwhile, the mother is praying. By the way, when Luke Fields was asked about the painting, the only thing he said about it is this painting is about hope that comes to us all at dawn. On the other side of the painting is the doctor. And interestingly, even though this is the era of the stethoscope, the ophthalmoscope, the blood pressure cuff, and all these new inventions of diagnosis, Fields deliberately chose to leave them all out of the picture. And I think it's because he did not want to distract from the singular attentiveness of the physician to the patient. This painting became enormously popular. It was swarmed when it was first displayed. Of course, this is before the internet and YouTube, and people had less to do, I imagine. It was put on postage stamps in 20 countries. It was made an infamous use in this country, where the AMA used it in a smear campaign. They printed 60,000 copies of this painting when Truman, I think, was proposing socialized medicine. They printed 60,000 copies of this with the slogan, "Don't let the government interfere with this picture." And it worked. It was the very first successful smear campaign, torpedoed socialized medicine. By contrast, in England, this painting was used to celebrate 50 years of the NHS. This goes to show you. Lots of discussion as to what does this image mean? Why did it resonate so much with the public? And let me tell you, it still does. This is one of the most popular paintings by the public, for the public, when they think of physicians. Why does it resonate? There's been volumes written about why is this painting so important. I must confess, I disagree with most of the interpretations. My own sense is that despite the title, The Doctor, this painting has nothing to do with the doctor. This painting is about you and me projecting ourselves into the role of that sick child. And if we're that sick, this is the kind of attentiveness we want from the system that's going to take care of us. To me, it echoes lines in almost any religious text you care to think of, where it's the Bible, the Quran. In the Bible, for example, the lines in Matthew, "I was naked and you clothed me, I was hungry and you fed me, I was ill and you cared for me." This painting, I think, speaks to the Samaritan function of being a physician. And I've often wondered, what would Luke Fields paint if he was challenged to depict the doctor in our time in the year 2019? What would that look like? And my great fear is that it might look like this. Now, this is not a great leap for you because the nature of what you do very much revolves around images. You have good reasons to be there. But it's a very sad thing for those of us on the other side, on the wards, that so much of our attention has been distracted by this. I got into trouble with this article for saying that the patient in the bed has become a mere icon for the real patient who's in the computer. And I coined a term for that entity in the computer. I called it the eye patient, like your iPad, your iPhone. And I said that the eye patient is getting wonderful care all across America. The real patient often wonders, where is everyone? What is going on? When is anyone going to tell me anything? So we have a real disjunction between our perception of the patient as viewed through the computer and the actual patient experience. I think that these photographs are instructive. This is Maxwell Finland at Boston City Hospital, a giant in infectious disease. I don't know the year of this. I would guess about 50s and 60s. Around the bed is a who's who of infectious disease. Morton Schwartz, who went on to be chief of ID at Mass General, Jack Remington, who's at Stanford. And as you can see, the patient is the focus of attention. The data set is simple. It's in the intern's head, probably, or on a clipboard. And contrast that with the bottom right, where these days, very often I find rounds don't seem to involve the patient at all. You can have rounds in a room and never actually go see the patient if you don't insist. And there's some reasons for that. We have an extensive data set. There's much more to digest and discuss. Nevertheless, it's worthwhile asking, is it dangerous to see such a transition? In your field, I feel like we've seen something very similar, as Dr. Jackson alluded to earlier. We've gone from people like me coming there every day and looking forward to that interaction and running into our colleagues from surgery and elsewhere in your suites. We've gone from that to people sitting at their desks and just reading reports. Even though they're able to access the images, my sense is that they're not looking at the images often enough. They're just reading the reports. Is that consequential? I think it is, for 4 reasons that I'm about to discuss. And again, I'm not naive. I recognize we can't go back to the Maxwell Finland model of all of us sitting around the bed. By the way, I should tell you a story about Maxwell Finland, the attending who was standing there at the bed with all those folks around him. I trained at Boston City Hospital, many years later, and Max was still alive, very much around. Maxwell Finland lived in the hospital. He slept in the hospital. He ate in the cafeteria. He jogged in the corridors. He'd been mugged in the corridors a couple of times. That was a different era, altogether different. Is there a consequence if we sort of switch to this remote model of medicine, if you like? I think there is. And the consequences are 4. I'll speak to them briefly in the time I have. Patient dissatisfaction, physician wellness, medical error, and lastly, the loss of a ritual. And this is why I was so excited to hear your presidential address, because I think there is a wonderful opportunity to come together around some of these things. Let me speak about patient dissatisfaction first. So it would be easy to find examples in the modern era, because most patients are not happy to be in a doctor's office and find that the doctor's attention is divided between the screen and them. One of my sons introduced me to the phenomenon of speed dating that he was engaged in. I don't know if you're familiar with speed dating, but it is you go to a restaurant and you have 5 minutes at different tables with individuals who are also there for the same purpose. Everybody's paying a fee. And in that 5 minutes, you rate them, they rate you, and at the end of the evening, you find that if the ratings are similar, then you get a phone number, perhaps. I don't know the details. But I do know this, that in that 5 minutes, if you spend some of it looking at a screen and not engaging with the date, your potential date, it just wouldn't happen. So I decided to find an example from before the computer era, because that would be too obvious, trying to get at what do patients really want. And the example I found that I think works best is the example of Anatole Broyard, and we teach his book in medical schools all over the country. He wrote a wonderful book called Intoxicated by My Illness. He was a very famous critic for the Times Review of Books, for the New York Times, and he lived in Manhattan, had a very visible life, and he got prostate cancer, and when he was dying, he wrote this book, Intoxicated by My Illness. He was a complicated man. We found out after the fact that he was actually African American and had lived his whole life posing as white in Manhattan for good reasons, to overcome, I would suspect, the prejudice that was extant at that era. But in his book, he writes about his doctor. He says, "My doctor knows all there is to know about the prostate, but I cannot sit down and have a talk with him about it, which I find a very great deprivation." What a curious organ. What can God have been thinking when he designed it this way? This is a question I have too, by the way. I would like to have a meditation, a lucubration, a bombination about the prostate. I can't do it. I'm forced to stop people on the street to talk to them about it. And then he goes on to say something very pithy. He says, "I just wish my doctor would brood on my situation for perhaps 5 minutes, that he would give me his whole mind just once, be bonded with me for a brief space, survey my soul as well as my flesh, to get at my illness, for each man is ill in his own way." I would paraphrase that. I would say that each man and woman is ill in his or her own way and is itching to be recognized as something special, something different. This is a fundamental need that I think all patients have. And if you question me, just think about an illness that you've suffered, trivial or serious, and how you didn't want to be lumped into categories, right? My asthma is nothing like yours, excuse me. My peptic ulcer has nothing in common with the rest of humanity, right? We all feel this need to be recognized as special. David White, a friend and a wonderful poet, has something he says coming from poetry, but I think it could be applied to patients. He says, "The ultimate touchstone of friendship is witness. The privilege of having been seen by someone and the equal privilege of being granted the sight of the essence of the other. To have walked with them and to have believed in them, and sometimes just to have accompanied them for however brief a span on a journey impossible to accomplish alone." This is really what patients want, to be recognized, to be witnessed. And I think at our peril, we have let that slip away increasingly as time goes on. I want to move to physician wellness. It's a topic that you guys are very familiar with. I heard your president refer to it. Let me just say that this is an epidemic. In primary care, by some estimates, 50% of primary care physicians are depressed. And if that's believable, this is a tragedy. And as these studies have been done, including at our institution, we're all finding that this is staggeringly true. We did a survey of burnout a couple of years ago and found that it was astonishingly high, not 50%. And the dean invested a huge amount of resources, money, formed committees, and in 2 years it was worse. We then hired the world's expert on physician wellness, Tate Shanafelt from the Mayo, and he is now the first wellness physician out of any institution. And with all the things we're doing, we've brought it to a steady state. But it's important because if a physician scores high on a burnout index, they have something like a 50% chance of leaving in the next 2 years. And given the investment costs of bringing someone to Palo Alto, there is not a system in the world that can afford that sort of thing. In radiology, I don't have to tell you, this is a common phenomenon. I've just touched on it because I know you're going to be discussing it extensively the next few weeks. High burnout rate among interventional radiologists, especially women. High burnout rates in general. And the causes are exactly what I heard your president allude to. It's the reading room environment, which at times we envy, but I imagine at times can be, confining to residents when they picture that as a career choice. Productivity demands, EMR and PACS, the intense regulatory environment, the role of the healthcare team not understanding quite what you do. I believe that you're grossly undervalued. I always leave your offices just in awe, not just of your toys, but your ability to see things that elude the rest of us. And I always think it's a shame that that magic is not visible to more people in the hospital, but also to the patient. The root cause, at least in my field, for unhappiness is, I think, the 4,000 clicks a day problem. We are spending so much of our time on the computer. A beautiful study by Krasinski showed that for every 1 hour of cumulative patient care, we spend 1.5 hours or 2 hours on the computer, plus another hour of our personal time at home dealing with our inbox. And I feel very sad when I see residents doing this because, they didn't sign up for this. We let them inherit this terrible system. And the root cause is the electronic medical record. The current day electronic medical record, to me, is a system of epic disaster, if you like. It was not designed for us. It was designed for billing, and at the time the federal government mandated that we should all go digital. There were really only 2 systems around that could deal with complex healthcare systems. And they are dominant, but they were not built for our ease. This is a problem we have to address. In the Boeing cockpit, every single thing that goes on there, every alarm that goes on, is for the safety of the passengers and the comfort of the pilot flying the plane. In our healthcare system, the average nurse hears 200 alarms in a 1 or 2 week period. What do they do when they hear the alarm? Try to find the button to turn it off. We're paying no attention to alarms. We are not using technology in the way it should be used. Frankly, we are the highest paid clerical workers in the hospital. And that has to change. The Stone Age did not end because we ran out of stones. The Stone Age ended because we had better ideas, and we need better ideas. They're coming, but as you know, we've spent billions of dollars with the systems we have. It's just really hard to dislodge them, so we have all these add-ons coming on. I'm going to move from that problem to medical error, which I think follows closely. As we know, in society, we're all getting distracted by our peripheral brains, as I call them, by these little things in our hand. They cause disastrous consequences on the roads, but they have consequences in medicine. I commissioned this cartoon because I was concerned how people just weren't looking at the patient. This caption says, "Let's get a CAT scan and consult the gastroenterologist and figure out why you're having these pains." When it's quite obvious he's been run aground by the Titanic. I mean, I joke, but I only half joke that if you come to one of our systems across this country missing a leg, no one will believe you till they get an orthopedic consult, MRI, and CAT scan. We just don't trust what our eyes are showing us. We did a study some time ago where we tried to get at a kind of error that only you and I know about. We asked physicians to give us anecdotes of oversights in the medical exam that led to a consequence, such as delayed diagnosis or therapeutic misadventure or exposure to contrast or death because of an oversight. And we published when we had 200 such cases. And the number one reason, as you can imagine, an example would be, people come in with chest pain, they're sent up for the CAT suite, contrast is being injected, and then the shirt falls aside, and people notice that there's a rash that looks like dewdrops on rose petals, that it's shingles. Or, commonly, as you well know, patients are admitted with abdominal pain or vomiting, labeled gastroenteritis, and the next morning you call us to say, there's gas in the scrotum. The person has Fournier's gangrene, or there's a hernia trapped in the femoral orifice or the inguinal orifice. And mind you, 3 shifts have seen these people and signed off how everything is perfect, every checkbox is ticked off. So the number one cause for these errors is we're simply not doing what we so beautifully say we're doing in the computer. And I joke with my friend Atul Gawande, who wrote a book called Checklist. I said that based on this study, I want to write my own checklist book. It'll be more like a pamphlet with about 10 things in it. And number 1 will be, patients have a backside and a front side. Nice juicy things happen in the backside between the bed sheets and the patient's skin. If you don't look, you will miss them, and on like that. So we're clearly not being as attentive to the patient as we might be. I want to come to the last thing, which I think has echoes of what might be important for us to discuss in terms of trying to get our specialties to share these common goals, and it's the loss of ritual. And I have to tell you a little story about my own understanding of ritual. So before I moved to Stanford, when I was in Texas, I developed a reputation as being interested in patients with chronic fatigue, as an infectious disease person. I did not seek this reputation. This is not a reputation you would wish on your worst enemy, because these patients are going to be difficult. They're going to be challenging. They're going to come to you with a chip on their shoulder because they've been disappointed by most people they've been seeing. Their families often disbelieve them. They're a bit of a societal joke, which is why perhaps you smiled when I said you would not wish this on your worst enemy. So they come to you ready for you to join the long line of physicians who've let them down. And I realized this early on, and on my first or second patient, I just knew I could not do this patient service in a 40-minute new patient encounter. I could not go through the bags of information they were bringing me and listen to their story and examine them and come up with recommendations. And so I hit on this method where I gave them the first visit entirely to tell me their story, without interruption. We know the average American physician interrupts their patient in 11 seconds. So if I ever go to heaven, it'll be because I held my peace for 40 minutes, I let the story evolve. And then by mutual agreement, we met 2 weeks hence for the physical exam. But to my distress, on that second visit, this patient, the first or second patient in this series, continued to have story to tell me. I could not turn the tap off. And I was in despair. What does one do? And so I decided I would just launch into my physical exam. We all have different ways of beginning the exam. I think that even though we recorded head, eyes, ears, nose, and throat, it's something, aggressive to go grab somebody's head as your first opening gambit. So I always begin with a shake hands gesture. I'm shaking their hand, but I'm looking for myotonia and clubbing and feeling for Dupuytren's and cyanosis and the warmth of the skin. And then my left hand comes around to feel the pulse, and I'm registering the rate, the rhythm, the volume, the character. And then my hand slides up to the epitrochlear lymph node, and I am now in my ritual, which has not changed one bit in all these years of doing it. If anything, it's become abbreviated, it's become smoother, it has a flow to it. And a very interesting thing happened. This voluble patient began to quiet down. And I had an eerie sense that the patient and I had slipped back into a primitive ritual of some sort that I didn't quite understand. And when I was done, the patient said to me with some awe, "I have never been examined like this before," which, if it was true, is a real condemnation of our healthcare system, because they'd been seen by multiple people, and what I did was a very simple form of that. And then when the patient dressed and I began to tell them the very same thing they'd probably heard elsewhere in Scott and White, Mayo, wherever they'd been, which is, this is not in your head, this is real. The good news, it's not coccidiomycosis, which was endemic there. The bad news is we don't know exactly what's causing this, but here's what we're going to do. And I always felt that if the patient gave up the quest for the magic test, the magic doctor, the magic serology, and instead began a partnership with me towards wellness, it was because something had transpired in that encounter. And I didn't quite understand it until I got to Stanford, and the joy of being at Stanford is all the other schools, law, education, they're all on the same campus, not across the freeway, not across the state, they're right there. And so I walked to my anthropology colleagues and I told them the same story that I just told you. And they stopped me right away. They didn't let me finish. They said, "Abraham, you're describing a ritual." And they taught me that rituals are all about transformation. We engage in a ritual to signify the crossing of a threshold. Baptisms, bar mitzvahs, funerals, inaugurations. Take weddings. We marry with great pomp and ceremony and huge expense to signal our departure from a life of loneliness, misery, solitude to one of eternal bliss. I don't know why you're laughing. I hope your spouses are not here. Well, I would submit to you that the ritual of one individual entering our healthcare systems, seeing one of my residents who's often 1/3 their age or 1/2 their age, telling them things that they would not tell their spouse or their rabbi. In my specialty, infectious disease, telling me things they would never tell their spouse. And one individual is dressed in a white outfit, with ceremonial tools in the pocket, and the others dressed in a ceremonial paper gown that no one knows how to tie or untie. And all of this is happening in a room whose furniture doesn't look like the furniture in your house or mine. Tell me this doesn't have all the trappings of ritual. And then, amazingly, one individual in this dyad disrobes and allows touch, which in any other context in our society is assault. You can't do that. I know there's been confusion at the very highest levels about this sort of stuff, but let me assure you, it is assault. However, the great privilege of our profession, the flip side to the fiduciary responsibility we have to our patients, is that we are privileged to examine their bodies, to touch. And my experience in California especially, where I have all these ethnic groups that I care for, they all understand ritual. They all understand illness in completely different ways. They have different beliefs about disease, but they understand ritual. And if you come in and do a half-assed prod of their belly and stick your stethoscope on the paper gown, they're onto you. They are onto you, just as you are onto a sloppy hairdresser, a sloppy barista, a sloppy mechanic. You may not do what they do, but you can tell when someone does it well. And so we are investing a lot of time at Stanford trying to make sure people examine patients with skill, being aware of the important ritual and the transformation. So this skill has to be passed on, and there's no easy way to do it. You can't do it online. You can't do it remotely. It needs one-on-one instruction. This is, I'm told, an Indonesian swords craftsman, ceremonial sword craftsman, and if he doesn't show this to the young boy, this art will be lost forever. Our profession is not that different. There are things that we have to show by example, by walking the walk, talking the talk and walking the walk, and by imparting it inefficiently but in memorable ways. What is the transformation? I mentioned to you that rituals are all about transformation. What is the transformation? Well, when you examine well, and I would say this extends to when you do an imaging well, then come out and explain to the patient what is going on, what you're seeing, you are preserving the personality, the identity of the patient by locating it on their body. You're validating the patient's complaint as being on the body, not in an image report somewhere or on a picture somewhere, a biopsy report somewhere. You are symbolically centering your attention on the body, on their person, as the locus of personhood and disease. As you know, if you've ever been ill individually, you crave that. Connecting the image or biopsy report or lab test to their personhood, to me, is a singularly important thing that we all must do. We do it through the ritual of the exam. You're in possession of these beautiful images, but very few patients have the richness of your interpretation or your wisdom or your knowledge. And I think doing that, this is very challenging. I don't quite know how you're going to execute this, but I do think that is where the future lies, because it's really powerful for the patient to do that. Many, many times I've taken an iPad up to the patient and showed them the image and tried to correlate with for them what it is we're doing. It's mind-blowing what an epiphany that can be. But imagine if you were doing it with the skills you have, as opposed to my clumsy way of explaining those things. So I would say that, as William Osler said, patients form an estimate of us by the way in which we conduct ourselves at the bedside, but I would say anywhere in the healthcare system. Skill, whether in the simple act of feeling the pulse, will establish more confidence in you than any diploma. I would say this applies to any encounter in your suites. I've had many experiences of going down to radiology, and it's always a little unnerving. You don't know what's going to happen. You don't know how it's going to unfold, whatever this happens to be, needle or whatever. And, I think because I'm a physician, I've had the great privilege of having an attentiveness from you that is really powerful. I can't imagine what it would have been like otherwise. Why can't we extend this as best we can to everyone else? I think the secret of the care of the patient remains in truly caring for the patient. Caring for their imaging and their procedures is terribly important, but also for you, for your satisfaction, for the great manifestation of your healing spirit. I would love to see you also be out there caring for them in very, very visible ways. We share one DNA. We're all in this very much together. Increasingly, there aren't many divisions. People see a healthcare entity and they make judgments from one interaction or from the cumulative effect of many. This is our calling. I would love to see patients share the kind of appreciation that I have for the wonderful things you do and the way I've seen it evolve in the last 40 years. Thank you for being so very attentive, and enjoy your stay here in Chicago.